My name is Mitch Belkin, and this is my brother Daniel. We're both radiology residents in Baltimore, Maryland. And today we are here with Dr. Bryan Carmody, aka the Sheriff of Sodium. Dr. Carmody is a pediatric nephrologist, an associate professor at Eastern Virginia Medical School, and one of the most prominent medical education thinkers and critics today. Bryan, welcome back to the External Medicine Podcast.
It's great to see you guys again. I hope residency is going well.
Before we get started, do you have any financial disclosures?
No, I don't.
All right. Well, we have a bunch of topics we would like to talk to you about today. Hopefully we get to at least most of them. But one thing that you've written about recently, been tweeting about recently, is this IMG legislation in the state of Tennessee. Can you tell us a little bit about what's happening and some of the background information, and then we can go into some of the details?
Yeah, it was a headline that caught my eye back in the spring when the Tennessee State Legislature passed a bill that would ease the requirement for international medical graduates to have to do residency training in order to get a medical license and practice in that state. And actually, since Tennessee passed that law, Alabama actually passed a similar law, over the summer.
So what is the stated goal of both Alabama and Tennessee's legislature? What's like the actual problem that they're trying to resolve by having international medical graduates who have some experience practicing abroad and are licensed abroad bypassing the residency application system and actually completing our U.S.-based residency?
Well, the stated goal of all this stuff is to address physician shortages, because, in Tennessee and Alabama, just like every other state, there's areas where there are not really doctors for people to see. And so the stated intent of this legislation is to ease the physician shortage by allowing a new stream of physicians to come in and potentially practice in those areas. But like you guys probably know, if you follow me, I'm kind of skeptical of a lot of the stuff that gets talked about when we talk about physician shortages.
It's interesting. I don't know. I think most of the people who listen to this podcast are physicians, but many of them aren't. And so, can you maybe talk about the residency selection process and how international medical graduates are treated relative to U.S. MD and DO applicants?
There was a time in this country when there were way more residency positions than there were United States medical graduates. If you go back to the original days of the residency match in the 1950s or even persisting into the 1960s, hospitals were hungry. They were eager to have resident physicians, and there simply were not enough U.S. medical graduates to fill all those spots. And so over time, a couple of things have happened to sort of make it easier for physicians who have received their medical school education abroad to come and practice in the United States. So, through the 70s, for instance, physicians who went to medical schools in other countries, it became easier for them to get work visas and to train and to fill those positions. At the same time, some people realized there was an opportunity, sort of from a business standpoint, to create medical schools to enroll U.S. citizens who had not gotten into U.S. medical schools. And so a number of medical schools got established in the Caribbean in the 70s and 80s. And so now we have a system where we have more than enough applicants to fill the available residency positions. There still are more residency positions than there are U.S. MD and DO graduates, but the remainder generally get filled by international medical graduates, which may be people who grew up and went to medical school in another country, or sometimes even have extensive practice experience in that country, and they want to come to the United States at least to train, if not to eventually live and work. And then many other international medical graduates are U.S. citizens who, for different reasons, have chosen to go to medical school overseas. And sometimes they go to school in some country that they have some tie to or personal connection to, or they go to school in Europe or Israel. But many of those, the bulk of those U.S. international medical graduates are folks who go to school in the Caribbean.
And so for the international medical school graduates, the one who are not US based from birth, who decide to come and do a residency in the US, or I should say, who want to practice medicine in the US. You mentioned some previous pathways that were available. I know that historically it was possible for somebody who did a residency, who came to the US to do certain types of fellowship training, could become a practitioner in the US without going through a full US residency process. I know of, at least in the diagnostic residency program at radiology program at Maryland, I know of people who came to the US, this was 30 plus years ago, to go through that process. Now, however, the main way, my understanding, is people applying essentially to complete a residency slot as though they were a graduating US MD senior. Is that correct?
So basically, I think the best way to think about this is to think about what the barriers to practice are for international medical graduates. So, one barrier is a licensure requirement. So any state in the United States has a certain amount of postgraduate residency training in the United States that's required. So if you want to get a medical license, you can't just graduate from medical school and get a license. You have to have at least 1 year of postgraduate residency training in the United States. And in every state, that's the way the system has been. And some states require 3 years. So that's one barrier. A second barrier is that even if you can get a state license, you may not be able to get hospital privileges in that specialty. To use my specialty as an example, I'm a pediatric nephrologist. So I did 3 years of pediatric residency and then 3 years of pediatric nephrology fellowship. If you were a pediatric nephrologist from some other country, you could come and do a pediatric nephrology fellowship in the United States and get 3 years of residency experience in the United States. But that may not be enough to get you credentialed at a hospital, because you may not be board eligible with the American Board of Pediatrics. And so you might have to come back and do some amount of general pediatrics training in order to be board eligible and then board certified and get credentialed by insurance agencies and hospitals. So basically what this legislation has done is it's removed that state licensure requirement, so that now people who have have some practice experience, who have been in medical practice in another country for 3 out of the past 5 years, or folks who have completed a residency in another country, now they're eligible for licensure. So that's what Tennessee and Alabama have done. That's different than the way things used to be. And in place of that, what they'll do is they'll work at a hospital that trains residents, and they'll do that for 2 years. And then they'll be eligible for an unrestricted medical license in those states. But one problem with this legislation, and I think one thing that remains to be seen, is whether those other barriers are going to come down on account of this or not. Whether hospitals are going to relax their certification requirements or not, whether insurers are going to, pay for, bills from these physicians or not. That's, I think, yet to be seen.
During those years that they have to be at one of these academic medical centers, are they going to be overseen by another attending physician, or are they basically acting attending physicians?
Yeah, that's a good question. And I think that that's not entirely certain yet either. Basically the legislature, passed the law saying, let this be so. But they put it upon the state medical board to write the administrative code about exactly how this is going to be implemented and how it's going to work. I think the intent, though, of having international medical graduates work at programs that have a residency is so that there will be some supervision, a more supportive system. And on the one hand, you can see that through a lens that's completely benevolent. That makes sense. If you've been practicing in another country, it would be a very steep learning curve to just come and start working in the United States one day. So it's easy to see that such a policy through that lens alone. And I think that's a true lens through which you can see it. But I think it's also easy to see it as a benefit to the hospitals, who now can shore up some of their staffing needs with a workforce that I think people will be very eager for these kinds of positions, and they'll get many qualified applicants for positions that might have been challenging to fill otherwise.
Where I did my intern year, some of the program directors may screen out applicants on the basis of, say, what year they graduated from medical school and select a younger cohort of incoming potential residents. Where I did my internship, there was maybe the exact reverse process. It's created an opportunity for program directors who are seeking more experienced applicants. And like, for instance, one of my upper year senior residents, who is technically a PGY2, was previously a transplant urologist, and then had done a nephrology fellowship, and then was completing his 3 years of residency. And it created kind of a very unusual circumstance where it was clear that he knew way, way more than many of the attending physicians overseeing him, particularly on topics related to the kidneys. It was just a weird.
Yeah, you're exactly right. I mean, back in the day when I was in residency, we had a resident who was a year ahead of me who had been in practice as a neonatologist. So, I mean, it was wonderful in a pediatrics residency program to have your senior resident be someone who actually, had run a NICU before, And you're right about program selection strategies too. I mean, I think the dominant strategy for many programs is, like you said, they want fresh graduates, and the sort of, I think the maybe it's obvious, but maybe it's a little bit hidden why the logic of that is that it saves you some time in screening. I mean, the assumption you're making is that if someone hasn't matched in previous cycles, and you're assuming someone who graduated 5, 3, whatever, how many years ago, that they haven't matched, which is an assumption, but you assume that if they didn't match, there's a reason for it, that they have some academic deficiency, that maybe they don't interview well, but whatever the reason is, you can try to figure it out yourself, or you can just trust the wisdom of the crowd and say, oh, well, they didn't match before, so why would I want someone who didn't match before? And I'm going to limit my ERAS filter to just people who are recent graduates. And many programs choose that strategy, I think, in part, if not mainly, for that reason. But you're right, there's another strategy that many programs employ, which is because they realize that there's a certain number of applicants, like the one that you described, and my own personal experience, or some of the folks we have in our program who have exceptionally useful experiences, but you have to be willing to read more ERAS applications to find them.
Yeah, and another thing I'm not sure that people outside of the medical field know about is that a lot of the IMGs are applying to 10 times, 20 times the number of programs that other people are applying, regular, like US-based applicants are applying for. I mean, it's not uncommon to apply to 300 programs, 350 programs.
Right.
So maybe let's get into your skepticism about this actually addressing physician shortages. I mean, everyone keeps hearing about the physician shortages, and I think that has that maybe you could argue that there's an anxiety within the medical profession about nurse practitioners, and other people are doing more and more of the work of primary care, and sometimes hire other subspecialties in medicine in order to fill that gap, because we don't have enough physicians. So why isn't this law going to solve all of our physician shortage problems?
Well, right. That's a good question. So, I started sort of thinking about physician shortages a little bit a couple of years ago. And whenever I hear discussion of physician shortages, I mean, honest to God, I sort of play this little game with myself based on what the person's saying. If I click on their bio, or if I listen to them talk longer, or whatever, what is their stake in this? And of course, this is true for, lots of issues, but most people who speak the most about physician shortages, they're not analysts, they're advocates for a particular policy solution based on a problem that they perceive. And there's nothing wrong with that. I mean, there's nothing wrong with that at all. But it means that I think a lot of people's knowledge about what they think they know about physician shortages is maybe not true. The first thing I'd say is, there's a lot of different things that might a lot of sort of individual problems that could be described from a certain viewpoint as being a result of a physician shortage. For instance, if I want to see a doctor and there's not that type of doctor in my hometown, I might say, well, there's a physician shortage. If I want to see my doctor because I'm sick and I call them and they say, well, our next appointment is in 2 months, I might perceive there's a physician shortage. If I'm a hospital who's trying to recruit someone for a particular specialty and I don't really want to have to increase the price that I'm paying to get that specialist, I might perceive that there's a physician shortage. But I would put it to you that almost none of those problems will necessarily be solved by simply producing more doctors and hoping that they're going to work in the places that you want them to work and practice in the way that you want them to practice. So, I mean, just to sort of build on the stuff I said before, I mean, if we look at those problems and sort of analyze them, let's say I'm in I grew up in a small town. We didn't have many specialists. But one reason that we don't have specialists is because it's not really a good business model. I mean, there's people who have rheumatologic disease or need certain surgical specialists, but there's not thousands and thousands of them, you know? And so you could train more vascular surgeons, but it may not ever be in anyone's economic practice best interests to go and practice in a place where you only have a day's worth of clinic a week, you know? And that's sort of, so you could train a lot more people and it wouldn't necessarily trickle down because you haven't addressed the incentives that keep physicians from practicing those places already. A better example is the one I gave second. I mean, like, I work with our pediatric residents. Many of them are going into general pediatrics. General pediatricians, it's pediatrics is not necessarily a very profitable area of medicine. If you want your practice to be profitable, you have to run kind of a tight ship. So however many patients that you're going to see that day, really you want to fill your schedule. You want all the people that you filled it with to come. You could leave 5 spots open in case some sick kids need to be seen that day, and many practices still do. But what if you only have 2 sick kids that day? Well, now you have 3 spots that were left open and the lights are still on and your nurses are still there and, electricity's, you're paying for all that stuff and there's no real work being done. Or you might have 15 people and you only got 5 spots. And so, it's not an efficient model. And so you could train more doctors, you could have more pediatricians, but those pediatricians will still face the same incentives that the existing pediatricians do, which is to fill your schedule to the brim. And anyone who's sick, you push them off to the urgent care or emergency department because that's simply a more efficient business model. You would have to change the incentives for providers to want to see those sick patients. You'd have to give them some incentive to want to get people in sooner, It's also, I think there's data to show this. If it's real easy to get an appointment at your doctor's office, people same day cancel more often. I mean, why wouldn't you? At the same time, if you've been waiting 3 months to get in, I mean, even if the weather's bad or you don't feel like going or whatever, you're kind of like, oh God, I mean, if I don't go, so unfortunately there's a perverse incentive to keep those waiting times somewhat longer, if you're a hospital administrator, and you want a particular specialist to work at your place and you say, oh, I can't, we can't hire someone to do this. The first thing you ought to ask is, well, have you tried raising the price that you're offering? and almost never is the answer yes. The perception of physician shortages from hospitals and medical groups is we can't find people to work here at the wages that we want to pay them. But of course, the way markets work is that if you want something bad enough, you should increase the price you're willing to pay for it. And so many of the places where there are physician shortages, I'm not sure that many, if any of them, would get better by simply training more doctors. I think you have to adjust the incentives that keep people from working in those places in the first place.
I guess the first thing that comes to mind for me is one way that these laws could change or help the physician shortages is by creating an underclass of physicians who train in this sort of other way. And because there's they're not universal. They can't just get privileges at any hospital. The specific hospitals that do allow them to get privileges would have much more negotiating power. And so that would be a way that they could say, okay, well, if you did this law, then you're going to be paid at this rate, whereas, a regular physician would get this other rate.
Right. No, I think that's it. I think it is. It has to be noted that this, these pieces of legislation passed with broad support from the hospitals and from insurers. And, those are corporations who, they have obligations to their stakeholders. They don't necessarily have, and their shareholders rather, but they don't necessarily have any obligation to, make life better for rural Tennesseans. They perceive that this is going to improve their business. The hospitals and the insurers perceive that this is going to, and so it begs the question, well, how would this be beneficial to those groups?
So in one of your YouTube videos, you actually pull out a map of, I believe it was Tennessee, and showing the areas that are shortage, quote unquote, shortage areas for not having sufficient numbers of healthcare professionals, and those that have a glut of healthcare professionals. And interestingly, they can be like in adjacent areas. It could theoretically map on to just where people who are physicians would like to live. But I guess if you don't think that this program, as currently designed with the current incentives, will actually fill need in areas where there are need, what are some alternative ways that we could improve physician shortages?
Well, I think that there's actually, when I started thinking about physician shortages, one thing that's sort of a little bit troubling about it is that there's not really any accepted definition for what a shortage of physicians is. And like I say, it sort of requires some, there's a context that's assumed when we talk about this, that, there's a physician shortage. But like I said, I think it comes back to, what is the problem that you perceive is evidence of a physician shortage? Is it that there's not a particular specialist in your area? You have to drive a long way to your doctor. Well, that's a problem that you could solve a number of ways. And maybe if that's the problem you're trying to solve, the best answer you'd come up with is, well, we need thousands and thousands of more doctors so that, to scrape by and earn, a living, maybe they need to, go to the places that aren't, and maybe that would work, maybe. Or maybe you could say, well, maybe we should give incentives for healthcare systems that have a lot of specialists to do more outreach. Maybe we should do that. Maybe we should, change our reimbursement or provide some kind of incentive for big health systems with a lot of capacity to say, well, you're going to go out and do this outreach clinic every so often for this specialty. Maybe that's a better solution to that problem. And you could go through that same logic with whatever face of the physician shortage you're seeing is making more physicians the answer to that or not. And if the idea is that you want to get more people into practice in these shortage areas, I think, like I said, that you sort of would begin answering that problem by asking, why don't people serve there already? And as you said, if you look at a map of shortage areas in Tennessee, one curious thing about it is that, in central Tennessee, you have, the city of Nashville, which has every medical capability as almost anywhere in the United States. And yet there are groups of patients very close to there who remain medically underserved. Now, why is that? It's not geography. It's not like, it's not primarily geography. My instinct is that it's probably that it's a patient population that lives there who, their insurance is the state Medicaid program, or they're uninsured. And it simply has not been a priority for the big centers who live right next to those shortage areas to address that shortage, because they're not being reimbursed as they might be for doing other things. So maybe you would say, well, if you're going to practice in this area, well, we're going to increase your Medicaid reimbursement.
Well, there's a lot more to talk about in this area, but we want to hit some other hot topics before the end of the interview. So the next one we wanted to talk to you about, it's something you've thought about and written about a lot over the years, resident unionization. And I think it's a little bit of a hot topic these days because they're in Boston, a number of institutions or residency programs unionized, and then some other institutions in the area gave pay raises to prevent the other residents at their institutions from unionizing. I'm at an institution that currently gave a big pay raise in order to prevent unionization. So I guess from your perspective, where do you stand in this? What do you see as the best arguments in favor of resident unionization? And maybe if you could also give the arguments against resident unionization as the people who are against it see it.
Yeah. Well, the first will be easier for me to answer, I guess, because I mean, my personal bias, I think, is that resident unions can do some good. I mean, so the problem, most of what I've talked about with unions is sort of an outspring of an argument I sometimes hear, which is that we need to get rid of the match. And so sometimes people argue that, if we got rid of the match, then residents would have the same power that practicing physicians do. If your employer is not good, well, you get a new one. You leave, you vote with your feet. If you have a skill that's in demand, then you entertain multiple offers. And employer one is inspired to give you more money or more benefits because the employer two is. And some people want that to apply to residents as well. But that's just not the basic economics of that system. As I said, we've got way more people who would love to do residency in the United States than we have residency positions, So the idea that that residents at large are going to benefit from a matchless system, I just don't see it, because you're going to have an incentive to underbid each other. And some of the people who argue that we need to blow up the match, they're people who've just gone through the match and they know how cutthroat it was. And if you had somebody that was like saying, "Oh, I'll work for this much less," the programs will of course choose them. When you have an excess supply of potential residents, there's no incentive to bargain or do any of those things. But if you think, medical residents are hardly the only employee group that finds themselves in that situation where they're individually replaceable. And that's really what the problem is that if you're looking to recruit interns, you can easily find one who's 99% of the one that you're looking at and without any trouble, but many other industries are that way, I mean, if you're a coal miner, you might be very good at mining coal, but probably it's not that hard to find someone else who could do what you're doing. And so I grew up in an area, in southwestern Virginia, where a lot of miners were in unions at that time, and it provided nice benefits and protection for them because individually they're replaceable, but collectively they're not. The mine doesn't work. And so that's what I perceive for residents too, because number one, because of the basic economics of supply and demand, individual residents are replaceable, or at least I'll put it this way: residents are very, very replaceable at the time that they're hired. And that's really the relevant time, because the other piece of it is that, because residency, it's work, but it's also an educational experience. It's not easy to transfer programs. It's not easy to change, to do something else. It creates logistical problems for you and for the program, So what that means is that once you're in, you're stuck, and the program has a lot of power over you. And I don't really see a way out of that other than collective action. So I think that the main reason that hospitals are opposed to resident unionization is economic. And you provided or sort of alluded to one of the best recent examples, which was, at the Massachusetts General Hospital, where amidst this, organization of residents and, plans to form a union, suddenly the hospital came up with, all these pay increases and nice benefits and things. And, it makes you wonder, well, where did all that money come from? And of course, the truthful answer is that they perceive that whatever money they might be paying, if that prevented the formation of a union, would save them money in the long run. And I mean, it is difficult for hospitals to work with unions. I mean, or any employer to work with unions. I mean, it's there's rules that you got to follow. You got to have your attorneys involved. You're at risk if you don't follow the rules of having complaints that are going to be expensive and difficult to deal with. So it adds a layer of difficulty for the employer that I think many employers would hope to avoid. But of course, the other issue is that in reality, unionized truck drivers, they make more than truck drivers who aren't unionized. And actually, you could argue, and I think economists have, that many of the benefits from people outside the unions are driven by the actions of the unions. So I'm not sure that there's really a legitimate argument other than economic for hospitals to resist resident unionization. And I think actually, if you were going to make an argument against unionization, I think the truest argument would be this: residency is temporary, and eventually you're going to be an attending physician. And the hospitals, when the residents union bargains, they might say, oh, well, guys, the union has really got us over a barrel here. We're going to have to, do without our, executive bonuses this year. That could happen. Or the people who at the top of the hospital may just say, well, guys, the resident unions really got us over the barrel. We're going to have to, cut our physician compensation and benefits by this much. And so it may be, and obviously the people who are making that decision have an incentive to protect their own compensation and positions and so on. But I mean, the money that is won by a union, it has to come from somewhere. I mean, it's not entirely a zero-sum game. I mean, you can have a hospital and a union that work together and they both benefit, but it's largely a zero-sum game. And so I think if you were going to make an argument against resident unionization, it would be, hey guys, take the long view, don't unionize, make less money for this 3 to 5 years, and you'll make slightly more money for the next 30. That would be, I think, the only truthful argument you could make, which I haven't really heard anybody frame because it doesn't sound good.
Play a little bit of devil's advocate here. So I could theoretically envision people coming up with, maybe medicine is an example I'm not as familiar with, but you could imagine problems with teachers' unions, let's say, where you could have teachers who are performing below expected targets who are just allowed to kind of glide by because of the ability of the union to prevent an individual from being gotten rid of. So another question that I would wonder about too is the power of the union comes from the threat of a strike, right? Like the power of the union is in large part from the ability to say, we're not going to work. My question as a devil's advocate here would be, what would a resident strike look like for patients?
Yeah, right. Yeah, I think you hit on something that's true. I mean, it is problematic because that's the primary tool that, it's the nuclear option, but it's the primary tool, or at least the threat of it, that has made many unions successful. And a resident union's, a strike. I mean, I think it has actually occurred. I mean, I believe it has. But I don't have those details at my fingertips. But I have a sort of a vague memory that in the 1980s in New York, there was a resident union that went on strike. But you have to fact check me on that.
I think that's right. I think also there's one in the UK, and some of them actually just they work, but they don't document any of the they don't do the documentation for billing. And then I believe the one in New York, and we'll have to put this in the show notes if it's wrong, but I believe mortality overall went down during the strike. During it, something like that. That was the people, anti-medicine people were excited about that.
But I would say there are still benefits of unionization that even without striking. I mean, because you have expert negotiators, who are acting on your behalf with the union. When you are part of a union, you're not negotiating your individual contract. People are doing that on your behalf, and the people who are doing that on your behalf, they know what they're doing, and they know what other residents get, and there's a high information cost, and there's rapid turnover with residents, such that without a union, you could do all those things. You could, as a resident, collect data and advocate and whatever, but the people negotiating with you, they sort of realize, you're going to be out of there soon. And, just like anything in residency programs, the rapid turnover and the fact that residents are so busy, it makes it hard to sustain a lot of things outside the program, So also when you're part of a union, like I said, a whole different set of, laws and regulations apply, to the negotiations that occur. And like I said, that's one reason I think that employers don't want to be involved in that if they can help it, is because all that's cumbersome and often, litigious.
Yeah, I think that in the position that I put forward, one of the obvious differences between a resident and, say, a teacher working for a teachers union, or a teacher working at a school and being part of a teachers union, is that the teacher ultimately has the ability to leave and take a position elsewhere. The resident is in this unusual position where there's really if you do not complete your residency program, you will not be able to practice medicine in the way that you foresee. So it's almost the incentive structure is somewhat different. Like, we're bound to the institution in a way that other employers may not be, other employees may not be.
Yeah, that's a good point. And I was going to comment on the teacher's example also, because that is a concern that, incompetent residents might be promoted or moved on because, part of being in a union gives you some protections about making sure that you've had due process followed. But I think that, in reality, that should be the case anyhow. And in reality, it's difficult to dismiss a resident even without a union. But the unions, I think, they have an incentive to, when people are not good, they should ensure that all the appropriate procedures are followed, that the person has documentation of their deficiencies and a period of remediation and, a chance to appeal and so on. They should insist that they get their due process, but the union really doesn't have an incentive to allow incompetent people to, pass through because of the union. That really sort of, that does threaten the union. And I think that their leadership kind of realizes that, and, they will fight to a certain point when there's residents that, are being dismissed, but the fighting is intended to ensure that the policies are being followed,
Just to follow up on what I said before, I found some literature. It looks like there were 5 strikes from the articles on PubMed between 1976 and 2003. The doctor strikes lasted between 9 days and 17 weeks, and all reported that mortality either stayed the same or decreased during, or in some cases after the strike. None found that mortality increased during the weeks of the strikes compared to other time periods. I'm not sure. Yeah. I think that they offer emergency care during those times, that they stopped doing elective things, but I'm not sure all the details.
Yeah, it's interesting. It's interesting to hypothesize, what differences in, patients might have been in the hospital, at the time of resident strikes, or how the hospital's practice model might have changed,
So there was one court case that is, I guess, related tangentially to this that you were tweeting about. I don't know if we're still supposed to call it tweeting or not, but we'll still call it tweeting. So there was this recent court case where I think it was like in 2019, but it just came up. This is Weisman versus Barnes Jewish Hospital. Can you tell us a little bit about this case and your understanding of what happened here?
Yeah, well, it is extensive, and the gist of it is that there was a resident who was recruited to an anesthesiology residency program, and it was sort of unusual. The resident had a lot of research expertise and experience, and was recruited sort of on those grounds. And there were discussions of having, a lab and all this stuff. And things turned south. His clinical evaluations were not good. And the program started working to try to get him out. And, it's not clear that all that was really sort of above the board. And, of course, there's two sides to every story. But the bottom line is the resident was terminated. And, all the promises that were made didn't materialize, and his lab and all that stuff disappeared. And I mean, it was a mess. So it ended up in litigation, and the part that was striking to me was, well, first of all, I guess it's worth comment that, I mean, it took years. It took years to get to the point where there was sort of a final judgment, and this is not even to trial. There was so many motions and so much, going on. The thing was finally dismissed, but it took years. And as a side note, I've got to say, like, that goes to show, the failings of the legal system as it relates to resident issues. Sometimes I've actually been thinking about making a video because I've gotten several questions lately from people who have gotten in trouble with their residency program, and they are looking for advice. And my advice generally is, your policies at your institution, that is your main protection. It's tempting to think, oh, I'm going to sue their butt off, but in reality, it won't work. I'm telling you, it's almost guaranteed not to work because there's no money in it for the attorneys in most cases. I mean, you can sue for a year of lost physician wages, but that's not really going to justify an attorney's involvement, to get you back a few $100,000. You really have to have some big damages to make it worth their while to take the case on contingency. Malpractice attorneys will take a case on the hope that it pays off a big settlement. And basically the attorney is acting like like an investor. They're investing their time and resources with the hope of a piece of a payout. But if you're involved in the civil litigation, you've got attorneys on one side who are being paid by a deep-pocketed organization, and you're going to be paying out of pocket. The Weisman lawsuit worked in part because Dr. Weisman is also an attorney. But anyhow, I kind of digress. The part that was jarring to me was that, the hospital and the university objected to everything. They objected to every single thing. Among them was the fact that Weisman didn't even have a contract. And so Weisman held up that they breached their contract because he'd signed this thing that he got after match day that goes on for 17 pages saying what he's going to make and, all the different policies that he's going to be held to and, all the standards and so on. And so he alleged that they breached their contract. And the hospital's like, no, that's not a contract. And had a whole legal brief about it. And to me, that was just sort of, aside from the merits of the case, to sort of allege that all the people who are there working for you, this is one of the biggest GME sponsors in the hospital, in the country. We're talking about Barnes Jewish Hospital in St. Louis, one of the biggest GME sponsors. So all the hundreds or thousands of trainees that are there every day, working overnight, shuffling around, putting in orders, taking care of the patients. They're actually doing that under some mistaken impression that they're contractually obligated to do so. And in reality, they aren't. They're not under contract. I guess they could just do as they please. They can't be held to it. I mean, for them to sort of assert that, and of course, it was a technical objection based on Missouri law. Missouri law says that a contract has to have this, that, and the other thing, and that document didn't completely apply in their opinion. But to me, that's just shameful. I mean, and obviously, I know that if you're sued, you probably don't want to waste any tricks. But I still feel like, as a matter of principle, you ought not make arguments that are just sort of like that. I mean, I would have a hard time if I were, whoever was dealing with the attorneys at the hospital, and the attorney's like, well, actually, I think we can make this argument. I'd be like, man, I really don't want you to have to go there. That just doesn't seem like an honest argument to me to say that, in fact, none of our residents have a contract, nor have they ever had a contract. I'm not gonna, let's attack this in some other way.
Very, very strange to to have that be part. I can understand like from a legal standpoint that you'll just attach yourself to anything that you think will help you win the court case, but to kind of allege that like residents are not in any meaningful legal contract at the hospitals in which they work is just very strange. It almost reminds me of the this strange thing where, as trainees, we as residents, at least in the state of Maryland, we are not entitled to some things that regular employees are. Like, for instance, like we can have a 401k, but since we're not employees of the hospitals, they won't match us. They'll match everyone else. They'll match the janitor. They'll match all the other important people in the hospital. But no. We're still in training here, so we're a little different.
Right.
We wanted to touch on a video that you made about the OBGYN ERAS divorce. This is the AAMC's electronic residency application system. So like a big revenue gatherer for the AAMC. I believe you said something like in 2022, $120 million worth of income. And now OB-GYN has decided they're going to set up a separate process. What's your understanding of the kind of rationale for this and how this may affect ERAS in the future more broadly?
Yeah, I think it's going to be a good thing as far as ERAS goes. I think either one of two things is going to happen. I think either ERAS is going to improve in the face of competition, that they're going to perceive a threat and they're going to be more responsive to applicants and programs, and they're going to make their software better, and they're going to benefit from competition. Or I think they'll fold, and there'll be a different product that people use. So, I mean, honestly, I think it's a good thing for applicants and programs, really sort of whichever way it goes, and I think that kind of like we were talking about with unionization and non-unionization, when one, group does something bold, often it benefits everybody. And I think that this benefits anybody who interfaces with the AMC, because now there's a legitimate acted upon threat that specialties will vote with their feet. Because I mean, there ain't no law that says you have to use ERAS. It's just what everybody sort of does by default. And so I think it's a good thing.
Yeah, it's occurring to me now that all of the topics that we're talking about today are all sort of on the intersection of medicine and economics and monopoly power. It also occurred to me while I was while we were preparing for this interview that, in a way, the OBGYN going and forming their own separate ERAS, and the Tennessee and now Alabama laws, where these IMGs who are spending Lord knows how much on their 300, 400 applications, now if they can go through this separate way, I don't know if it's through ERAS. I assume it won't be through ERAS, to have their own way of getting into the system within Tennessee or Alabama, but basically where they're just slowly eating away at the incredible profits that the AAMC manages to rake in through ERAS.
Yeah, right. Yeah, and I think you might have seen this on X or Twitter, but I mean, I was trying to highlight, I think ERAS is under serious threat right now. I mean, OBGYN is still in for now, but I think the bigger problem is, the proliferation of high preference signaling, high number preference signaling, which you guys have probably, followed a little bit, although I guess it sort of, didn't affect you as much. Several specialties, starting with OBGYN and orthopedics, asked the AMC to allow preference signaling through ERAS using a high number of preference signals. And I know that those specialties knew exactly what they were doing when they did it. When a specialty uses a high number of signals, it functions as a soft application cap. Because, for instance, last year, orthopedics allowed each applicant to have 30 preference signals. Well, if you get an application from some applicant who doesn't send a signal to you, I mean, you can review it and you can invite them for an interview, but you already know that you're at best their 31st favorite program. And is that really worth your time and your faculty's time as a program to do it? Probably not, And so programs they get so many applications that are signaled that an easy first step to reviewing applications is simply to look at those and find enough applicants to interview. And so last year in orthopedics, if you did not signal a program, your odds of getting an interview were about 1%. And even that 1%, I think, is misleading, because I think many of those applicants, in truth, were an applicant who had done an away rotation, or that was their home institution. And the program director was like, don't worry about signaling us. We're going to interview you anyhow. I don't think that very many of that 1% were even people that were like, well, we've got all these signal applications, but let's see what else is going on in this pile over here. So what that means is, a couple of years ago, orthopedic surgery applicants were applying to, 90, 100 programs apiece. And I think many people will still apply to a lot of programs, but as each year goes by, I think orthopedic surgery applicants are going to see that you're really kind of wasting your money. Applying to places that you haven't signaled, unless you have some credible reason to believe that they're going to give you an interview without signaling them, or unless you think that for some reason that program is going to be undersubscribed and they're just not going to get enough signals to look through. So, starting with orthopedic surgery and OBGYN, they went with big signaling in the past cycle. And now a lot of specialties are doing it. Urology is doing it. Neurosurgery is doing it. For you all, diagnostic and interventional radiology together, I think it's 12. You get 12 signals. So not as high, but that still is going to have the same effect on decreasing the number of applications. And as I said, that effect is going to magnify in each cycle as applicants get more comfortable with the real life data that are going to show that, your odds of getting an interview at a non-signaled program in these specialties that use a high signal number, it's not good. So I think that puts them under stress, or at least under threat. And I think you can see that in some of their policy decisions.
So I guess let's jump to a couple of rapid fire questions. What is one medical truth, or maybe economic truth, or medico-economic truth that very few of your colleagues agree with you on?
I think one that I've been quiet about, that I think is absolutely true. I've talked about it some, but I don't put my neck out on this one on Twitter because people don't like to hear it. But, recently there's been another, upheaval of anger against the American Board of Internal Medicine. And of course, there's smoldering anger about the American Board of Pediatrics and the American Board of Radiology and so on, in particular related to their maintenance of certification programs. And I think it is a myth that there is really anything realistic that can be done to end those programs. I think that simply it will not occur. Now, there's one lawsuit that remains pending that could, that could expose these organizations to an antitrust threat, and that would shut it down. But, there was previously, a lawsuit against ABIM and ABR, and that failed, So I'm not optimistic about it. I do not think that there is a way to end MOC, and that's unpopular. But these organizations, they exist because they can, and they simply will not choose to not exist.
Is there some like one of the things that we've been talking about today that you feel like this actually might be a good solution to this problem? If you just had like a few $1 million, you could fund a small scale version of it.
Well, I'll tell you, this is sort of getting off the topic maybe a little bit, but I'll tell you a policy I wish I could impose. Because I guess if there's been a theme in our discussion, it is that, people do things for a reason. And the incentives that inspire those choices, that's the lever that we have to make people make different choices. So I wish that we would fund graduate medical education in a more sensible way. And we spend a buttload of money to support graduate medical education in this country. Most of it comes through CMS, through Medicare. But the way that money is allocated is completely nonsensical. It is completely nonsensical. It's the end result of a lot of different political compromises over time that sort of grandfathered in certain residency programs and certain payment schemes. And it makes no sense. And if you step back and you think, from a policy standpoint, if you say we're going to spend X billion dollars supporting graduate medical education, would you not want to have some social return on that investment? I mean, would you not want then to have the power to sort of direct workforce creation in the areas that you want, and support people who are going to serve things that you feel are in the public's best interests? I mean, given that we're taking this money that could have been funding schools or building roads or something that might have benefited every person, and instead we're going to just sort of ship it off to urban hospitals in the Northeast to pay residency programs that maybe that's not the best use of that resources. So what I wish we would do is take all that money, and obviously there's no political wherewithal to do this, and it would harm a lot of the people who benefit handsomely in this system right now. But I would take that money and I would come up with sort of, I guess for lack of a better word, sort of a voucher system where instead of Medicare sending a check to your hospital for training you, I would give a trainee a voucher that their hospital, they could then give it to their hospital that trains them, and the hospital could redeem it for a certain amount of CMS cash. But in doing that, and we wouldn't even have to spend any more money. We could take all the money we're spending now. But in doing that, now all of a sudden you have a mechanism through which you can say, well, somebody, if you're a resident or you want to train and you're going to go and work in one of these underserved areas, well, how about I give you one of these vouchers? You apply and you want to do that, you get a voucher. That's going to make you much more attractive to residency programs. I mean, people would love to have that, money from CMS, of course, and you might be able to get a societal return on investment on that. Or if you felt that, gosh, we're training enough people in this specialty, but not enough in this. I mean, we need more radiologists, for sake of example. Well, we could say, well, this year we're going to give more vouchers to people doing radiology, because unfortunately right now, a lot of things go into the decision about whether a hospital may want to have a residency program or not. But whether there's a future societal need for the people that they produce, that they're training, is really not a part of that calculus at all. So it would also give residents more power, because they could vote with their feet. If they did transfer, you're going to lose that money. There'd be not just the indirect hit of losing a resident, but you'd also lose their CMS funding stream. If you want to mistreat people or harass people or abuse your trainees, so to me, it would be a more sensible, more flexible system that could increase the return on investment that we're all, contributing to through our taxes, and not even cost any more money. But of course, it would harm the people and entities that benefit in the current system.
Very interesting idea. All right, last question. What is the most underrated article in the medical literature? Or it could be, you read all sorts of stuff in law and economics, but what's one thing that you would think more doctors should read?
One of my favorite articles that I love to teach about, and this may not be interesting to you guys, but there was an article in the 1970s called Acute Renal Success. And oh man, I love that article because when I teach renal physiology to our second year medical students, we talk about the function of the glomerulus and the function of the tubule. And sometimes, every now and then, I get a smart medical student that asks me, why is it in acute tubular necrosis? I mean, if it's the tubule that's damaged, why is it that the patients don't have urine output? I mean, that makes sense if the glomerulus is damaged, but why, if you're still filtering, why don't patients continue to have urine output? And of course, that was a question that had troubled some other nephrologists in the past. And there's a beautiful, just like everything that the kidney does. I mean, everything that the kidney does is to keep you alive. If you think you're smarter than it, you better think twice, because it is what permits life on dry land. And so, in that time, we didn't talk about acute kidney injury. We talked about acute renal failure. So the article was called Acute Renal Success, the unexpected logic of oliguria. And the idea was that somewhere, eons ago, one of our genetic ancestors, developed this physiology where you had tubuloglomerular feedback, where the tubule talked to the glomerulus and told it to shut down so that you didn't pee yourself to death. So somewhere, I mean, somebody's, I don't know, great-great-great-great-great-grandfather got, I don't know, bitten by the saber-toothed tiger and had hemorrhagic shock, and they had ATN, and they laid in their cave, and they shut down their glomerulus, and they conserved their fluids. And somehow days later, they were able to stagger up, and, their AKI resolved, and they went on to pass on their genetics and physiology to the rest of us, And so it's, I think it's a beautiful article that highlights sort of a broader principle that is almost everything. I mean, for our kidneys and other things too, that initially seems paradoxical about, gosh, why do our bodies go wrong in that way? Why do they not make this decision, which obviously would be so much better for, this disease state? There's a reason for it. It's been evolutionarily endowed to us. And when you understand that reason, I mean, it kind of leaves you in awe of the human body, but I think also gives you insight into, how to fix it when you're in that position.
Before we close, I don't know if you know this, our grandfather was actually a pediatric nephrologist.
I think you told me that. Yeah, you were reminding me. Yeah.
Yeah. So we love the kidneys. Actually, I don't know if Daniel loves the kidneys. I've always loved the kidneys.
I love the kidneys.
Yeah. Anyhow, Bryan, thank you so much once again for joining us on the External Medicine Podcast. We're going to link to your YouTube channel and your Twitter and your website, of course, in the show notes. But always a pleasure to have you on.
Oh, it was a pleasure to chat. Wishing you guys the best.
Podcast is for educational and entertainment purposes only. We do not endorse any healthcare providers or treatments. Our views do not represent the views of any official organization or institution. If you'd like to support us, subscribe to this podcast wherever you get your podcasts. Leave us a review, preferably a phenomenal review. Visit us at externalmedicinepodcast.com and tell your friends.